contact point. So when we are doing the prosthetic part, the distance between the contact point and the crest of the bone has to be kept more than 5 millimeter. At least for 5 mm it is for the teeth, more than 5 it is for the implant. So that need to be taken care. Another is the distance between the implant and the tooth. The distance between the implant and the tooth has to be at least 1.5 millimeter. And when the distance between, if there are two adjacent implants, there has to be a at 3 millimeter distance. Now this is beforehand. Now if the implant has been done and if the black triangle has been developed, the only way out is the papilla reconstruction surgery. As I showed you in the picture, using again a connective tissue graft and or the PRF, and then we need to do a papilla fill surgery, like putting this graft and then coronally advancing and suturing it.
Thank you so much, doctor. Any other questions, please, doctors? Our speaker will take them. So we have another query. If we move the teeth orthodontically for implant placement, what are the chances we will get a matured bone and gingiva for implants?
Yes, see, the gingival movements also, see, the gingival movement in the implant site will not happen by ortho. When the teeth are moving, the gingiva around the teeth will change, the positions, I mean to say. But in the implant site, the gingiva will not change. But yes, only you will create a space so which will be sufficient to put the implant. But if you are expecting the bone width will change or the bone dimensions will change, no. The soft tissue dimension in the edentulous area will not change, but they will change around the teeth.
Right. Thank you so much, doctor. Apically displaced flap round implants procedure. Could we just have a quick brief on that?
See, frankly, yes, I will try my best, but verbally explaining, they are very difficult, rather than okay. See, apically displaced, as I said, is the name suggests. So what you need to give is two vertical incisions. Then you reflect the whole flap by periosteum. And whenever you want to displace, now you can try on a patient also, you have to go beyond mucogingival junction. Normally what we do, we just reflect 1 to 2 mm and that's all. That way we will not be able to move the flap. So अच्छे से reflect करो flap को where it goes beyond the mucogingival junction. And you remember, as I said, beyond mucogingival junction is the alveolar mucosa, which is very freely movable. So as soon as you cross the mucogingival junction, it becomes very free to move, and then we can put it apically and suture at the bone level.
Thank you so much, doctor. Could you please repeat the Vista technique and difference with TCAF, tunneling and Vista?
Okay. See, Vista technique, again, as I said, it's a minimally invasive. So what we do is, instead of reflecting the flap from the bone crest, a small incision is made near the, like what you call as a vestibule. Okay, that is why it is called as a Vista. That is a vestibular exchange. And then a vestibular approach. That means through that small, what we are doing, the opening, through that the graft is pushed coronally till it goes to the free gingival margin. So in this way, we achieve the thickness. So there is no suturing done there. You imagine, only a small incision is done, and through that the graft is inserted. So there is no suturing, and it is very minimally invasive because the incision is towards the vestibule. So it will not be seen aesthetically.
Thank you so much, doctor. You also mentioned about hyaluronic acid to fill up space due to loss of interdental papilla. Is that right?
Not hyaluronic, connective tissue graft, I said. Correct. Either connective tissue graft or PRF can be used. Hyaluronic acid, it is a, yes, current evidence is they are trying, as I said, micro needling. I didn't say hyaluronic, it is a IPRF. IPRF has a growth factors, and which is more scientifically accepted as compared to the hyaluronic acid. Yes, the research is going on, but still it is not very accepted, the hyaluronic acid. But IPRF, yes, we get very good results.
What is poncho technique in this technique? Free gingival use or connective tissue graft use?
No, it's only a connective tissue graft, no free gingival graft. Poncho technique, as I said, is to increase the vertical thickness of the bone, or vertical thickness of the soft tissue in the implant side. So once the implant is been done in that area, if the soft tissue is thin, less than 2 millimeter, the crestal bone loss is more. The chances are more. That is been proven. So what is done so as to cover that, as I showed in the picture, we put a cover screw or when we try to put a healing abutment, we make a small hole in the center by piercing the connective tissue graft, or even a PRF can be used, and then it is kept over the implant. See, like this. See, can you see this hole? So this part is going on. Can you see this? This is a simple diagram to understand. So this is called as a poncho. So my this healing abutment, I'm piercing it. This is by simple rubber dam punch. Okay, so we make a punch in the connective tissue graft. We pierce the healing abutment. Abhi ye healing abutment, what I'm going to do? Here is my implant. So I'm going to put this healing abutment here. So this part will go buccally, this will go lingually, and my healing abutment will sit in the center. So if this part will be like covering the buccal section, this will be like suppose the lingual section. So I'm adding some tissue over here, and so automatically my vertical thickness here is going to increase. That is a poncho technique.
Thank you so much, doctor. Could you explain about zero bone loss?
Okay, zero bone loss concept. This is the same like background for the zero bone loss.